Oh, good morning. It's nice to be here. Nice to see everybody out so bright and early on a Friday morning. As Roseanne mentioned, we're doing a project under the Center for Clinical Decision Making, working with the Department of Medicine House Staff Training Program, potentially with the medical school faculty, on some concepts of bedside decision making, and it's built around a cognitive checklist or decision making card. The background of this whole project is the whole issue of diagnostic error and the whole patient safety movement. Should this light, can you see those back there? Okay. You want this? Let me just, is that better? In the whole patient safety movement, diagnostic error remains a very serious but seriously underestimated problem in the patient safety movement. Precise estimates of the prevalence are difficult to make, but data from a number of sources suggests it's in as many as 10 to 15% of cases, a very high prevalence. It's estimated 40 to 80,000 hospital deaths per year are due to misdiagnosis. And more recent data actually suggests that that number may be a serious underestimation of the actual frequency. We get this data from many different sources. One source is from autopsy studies. They're done infrequently today, but if we look at serial studies, autopsy studies, even when normalized to 100% autopsy rate to try to eliminate selection bias, suggest that the prevalence of diagnostic error is 8%, with class 1 error being 4%. Class 1 means an error that, if known, would have changed management and likely would have changed or could have changed outcome in terms of survival. And that would estimate, so that's 1 in 25 cases of hospital deaths, about 35,000 deaths per year. In a recent paper just last year of patients who die in an intensive care unit, prevalence of misdiagnosis is estimated to be 28%, with class 1 error rate 8%. So 1 in 12 patients have a misdiagnosis that could have changed management and potentially survival. Would account for 22 to 40,000 deaths per year. Other sources of data are insurance plan population studies. The most frequent one is the Harvard Medical Practice Study, the first and best known one. Of adverse events due to physician error, misdiagnosis was more common at 14% than medication errors at 9%. They were more likely to be judged to be negligent and to result in disability, 47% versus 14%. And there have been similar findings from numerous other cohort studies, Utah, Colorado study, Canadian study, Australian study, except these studies are showing even considerably higher frequencies in terms of misdiagnosis. And another source of data is the malpractice database. This study just done this year from the U.S. National Practitioner Database looked at 25 years worth of data, 350,000 claims. Diagnostic error was the #1 cause of malpractice litigation, almost 30% of all claims, and accounted for a total of 35% of total payments. The total cost, $39 billion related to misdiagnosis. These are similar data. This was from the Harvard Crico malpractice insurance study. This is looking at numbers of claims, and this is looking at cost. We see down here medication-related claims. Actually, in frequency for litigation is a relatively small factor. Obstetric-related claims, medical treatment, surgical treatment are down at that level. These are all the issues that were addressed in the Institute of Medicine report on patient safety. The elephant in the room, however, is this. Diagnosis-related error was about 3 times more common as a cause of malpractice litigation. I'm standing in front of you. Can you see? 3 times more common as a cause of malpractice litigation and 3 times more expensive as any of these others. And yet, if we look at the Institute of Medicine report, they had the words medication errors 71 times in the book. I'm not the one who counted, but I was in a meeting this year. Somebody did. The word diagnostic errors is in there twice. So diagnostic error, the IOM report just didn't go there. They didn't try to tackle that because it's a very complex problem, but it's a very important problem in patient safety. So the question comes, can we enable and empower physicians to make more accurate and more cost-efficient diagnostic decisions? In part, this has to come from improvement in systems. Electronic medical records are an enormous asset. We have an enormous investment and they're a big asset. I think all of us also recognize they're also a liability because these are imperfect systems, vendor-built systems. Paul and I were at a meeting this week. There's an International Society to Improve Diagnosis of Medicine, believe it or not, and they had their international meeting in Chicago this week, and we were there. They had a session, are EMRs helping or hurting the diagnostic process? The very fact that that was a topic of discussion points out that while the EMRs, and I'm a big supporter of them, while EMRs are a major asset, they're also a liability because they're imperfect systems made by vendors. Other systems to improve diagnostic decision-making can be computerized decision support tools. These have been widely promoted and have substantial potential, but thus far have had very limited impact despite 30 years of effort. When I came here in 1980, there was great enthusiasm about the work being done on computerized decision support. But since then, companies have come and gone bankrupt. The market penetration of these systems, while the potential is there, the impact has really been very limited despite 30 years of quite dedicated work. A critical factor when we look at how do we reduce diagnostic error is to be aware of the fact that knowledge deficits are typically not the cause of diagnostic error. The cause is more commonly faulty synthesis of data. We're not missing the esoteric zebras that nobody's ever heard of or the incredibly atypical presentation of disease. The things we're missing are the pneumonias, the cancers, the aortic aneurysms, and the more common things. So as these are looked at, the most common single factor contributing to diagnostic error is faulty synthesis of data. So a major component of the solution has to come from a reduction of cognitive errors in decision-making. And this is a topic when what started the whole patient safety movement with the IOM report just was not addressed at all. So the challenge then is it possible to teach physicians to make better diagnostic decisions? To think about this, it's helpful to know a little bit about the background cognitive psychology of how humans, including doctors, most of us are considered to be human, some of us, but how humans go about making decisions. And the prevalent theory that I think is widely accepted in the cognitive psychology literature is dual processing theory, which basically says humans use two different mechanisms to make decisions, type 1 and type 2. Type 1 is far and away what we use for the vast majority of decisions. It's intuitive in nature. It's rapid. Uses heuristics or cognitive rules of thumb. That term comes from carpenters. Instead of running outside to get their measuring stick, they go like that. Yeah, it looks like 2 inches, and they go on. It's fast. It's an efficient way of making decisions. It's experientially based. It's cognitively efficient, and it's based on inductive logic, meaning it's based on experience. You recognize patterns. It's context dependent. So how you make a decision in a given presentation or a given set of facts depends on the context and how they're presented. It's qualitative in nature. It's hardwired, and it's multi-channeled, and I'll get back to that. There are many factors that affect it. Some of it hardwired, some of it emotion. Different factors can affect how we make these rapid type 1 decisions. They're usually accurate, but they're also subject to error. And biases leading to these errors are inherent in human judgment. In the current incredible resource of Wikipedia, right now they have about 100 cognitive errors that have now been cataloged as potential errors contributing to type 1 reasoning errors. Now, I've brought up just a few common ones that are particularly relevant to diagnostic medicine to give you an idea of these. One is availability heuristic. So heuristic says if you have something that's fresh in your mind, or you saw a case a month ago, or it might have been a case 4 years ago, but one that really had a big impact on you, you're much more likely to bring that out in your mind when you see a new case, either correctly or incorrectly. But it's available in your consciousness, you're more likely to apply it. Anchoring bias is retaining the initial impression regardless of new data. So the data on diagnosis, physicians start thinking about a diagnosis in the first 15 to 20 seconds of an interview. And they start focusing on it, and they start retaining that impression regardless of whether new data comes along that may be contradictory. And related to that is premature closure, which is a reluctance to pursue alternative possibilities. We get focused on one, and therefore back off and stop thinking about other ones. Confirmation bias, we selectively seek information to confirm what we want, not to dispute. So when we get a hypothesis in our mind, we start looking for evidence. Cognitively, we start looking for things to show me that I'm right, rather than looking and saying, look at all the data, is there some out there to show me I'm wrong? It's a natural bias. Framing effect is a very important one. Decisions depend on how information is presented. So if I send a patient to Paul's ER and I call down there and say, I'm sending in a patient with shortness of breath and I think he has worsening of his heart failure, the ER physicians are going to be much more likely to miss that patient's pulmonary embolism because that patient has walked in the door in the context saying this is heart failure. So everybody starts looking at it from the context of heart failure, and it's much easier to make mistakes because of how it's originally framed. Representative bias is the failure to take into account atypical presentations of disease. We all have in our minds sort of the typical patterns of how diseases present, but with representative bias, we tend to underestimate the variability of presentation and fail to recognize atypical presentations of even common diseases. Another important one is base rate neglect. This is a failure to consider prevalence. All of you are familiar with Bayes' theorem, but if you're diagnosing something that it's a zebra, you want to step back and say, well, is there something that's far more common that statistically can be more likely to be the real diagnosis? Doesn't mean that uncommon things don't happen, but sometimes we go there before we need to. Missy, there's some more chairs up here. Come on. I don't want to see you standing there. Please come up. Affective bias. Affective bias is visceral bias or countertransference. Humans are like that. So if we have a patient who is rowdy or violent or disheveled or smells or for whatever reason that we don't like them on an emotional basis, it affects our judgment. And these patients, diagnostic error is more common because you walk in the room with that affective bias that's clouding your initial judgment. Overconfidence bias. This is the degree of uncertainty correlates poorly with accuracy, and there are studies that have looked at this. And physicians not only are unaware of when they are misdiagnosing, they're particularly confident that they're right when they're wrong. And data have shown that. So misdiagnosis is like bad breath. We're only aware of it in others, and we're not aware of it ourselves. That was a quote from the meeting this week that I thought was pretty good. Another is search satisficing. A tendency to call off the search once something is found. So patient comes in the ER, they've got an injury, you look at the x-ray of the leg, you see the fracture above the ankle. You're much more likely to miss the second fracture up in the leg because you find the abnormality, your search is satisfied, cognitively say, okay, I've done it, I know what's going on. You go ahead and data clearly show you're much more likely to miss the second finding once you found the first one. And vertical error, we tend to think in silos. We categorize things and we think in silos, but there are times when we need to think outside the box. These are when the patients come in with the atypical presentations. So the alternative to type 1 reasoning, which is what humans use for the vast, vast majority of all decisions, is type 2 reasoning. This is an analytic process. It's rational. It's quantitative. It's objective. It's scientific. It's based on hypothetico-deductive reasoning and normative reasoning. It employs principles of Bayes' theorem. Problem is it's slow and it's cognitively taxing. That's why we don't use it for all our decisions. We don't have the mental power to be able to use it routinely. Inherently, it's more accurate than type 1 decisions, and it's particularly of value in circumstances of complexity. This accuracy was debated for a while, but there seems to be consensus that it is. And here is a model of this concept from Pat Crossgary, who's been a very prolific innovator in this whole field in medical decision-making and dual processing theory. This is his slide. If we see a patient, we have our pattern processor. And we see it, if we recognize them, we shift into type 1 reasoning. As I mentioned, it's multi-channel, but we go through the rapid reasoning to calibration and diagnosis. We see it, we recognize it, we go right ahead. If our pattern processor doesn't recognize what's going on, we shift over to type 2 processes. These are slower. We work through to calibration and then to diagnosis. Now, there's data, the T is for toggle. There's data that as humans making decisions, we toggle back and forth between the two. So it's not an either or, one or the other, but we'll employ one, shift to the other, go back and forth. There's also data that type 1 processes can be used for type 2 processes can be used for executive override of type 1 cognitive decision making and can be used to potentially correct the rapid reflex decisions where your analytic systems kick in and say, well, wait a minute, think about this, something else, and may enable you to correct an error from any one of the 100 biases that may mislead you. Alternatively, there's also evidence that it goes the other way, which calls dysrationalia override, where the evidence clearly says one thing, but we reflexly react and we say, well, yeah, there may be guidelines that say I should do this, but I really think I should do this. And I think I know that, when in fact the data would say that's not rational because the evidence base behind the guidelines is strong. Not that there isn't individual variability, but this can cross both ways. And then finally, there's this concept that if one can potentially take type 2 analytic processes, and when used repetitively, they can be built into your pattern recognition and ultimately become type 1 of a heuristic reflex process if it's used enough. This is part of what education is about in training. When you see your first case of pneumonia, you may not recognize it, but when you see your 10th case, you're getting pretty good. And when you get to your 100, boy, you really recognize those very quickly. So a basic premise here, and a premise that I have clinically from the bedside, is the key to making accurate and efficient diagnostic decisions is to systematically ask yourself and your patient good questions, focused questions to lead you to answers. And it got me wondering a number of years ago, for a reason at the point in my career, something came up where I got thinking about this and said, is it possible to write down in any kind of concise fashion the logical questions that one should ask themselves in the diagnostic process? It's a very simplistic type of thing, but it's about asking good questions. So can we identify those questions? So I began trying to write down in a concise fashion the questions that I would ask during the diagnostic process. And another focus of this is my orientation and belief, if not passion, is approaching diagnosis. We have to always reflect back to physiology and pathophysiology. And there's a lot of evidence in our training programs today that we're losing that, and we're losing it more and more. More and more we're taking care of patients by images and losing that knowledge of physiology and pathophysiology. Psychologists call this causal reasoning. So I started in a very primitive way. It was about 3.5, maybe almost 4 years ago now. And I just started trying to write down. It was totally simplistic type of thing. Well, what questions do I ask in the process? And I had a little laminated card with 5 or 6 questions and started using it. So whenever I would start an attending rotation, I would pass that out. Say, we're going to use this on this rotation. And as we saw cases, we would pull it out and use it. And then if we made a mistake or saw a mistake, we'd step back and look and say, well, where in the decision-making process did this go off tracks? Where was the mistake in the thinking? Could we identify it? And so based on that, kind of iteratively refined and reviewed the card or the questions based on real-world cases. This is a totally anecdotal, unscientific approach, just bedside thinking about how do we do it. And over about 3.5 years, usually on attending rounds or in clinic or when I'm seeing patients, when I see a mistake, go back and say, can you identify what question was missed that led to this mistake? Again, a totally random way. So this was initially developed exclusively from the context of bedside clinical experience, completely independent of any reference to cognitive psychology principles. There's a very logical reason why I did it that way. The reason is I had absolutely no clue that that literature existed. And I was doing this for a couple years and thinking, well, you know, maybe I'd try and write something about this. And so, well, maybe I'd go look and see if there's a literature. And I go in and, whoa, There's 40 years of literature on the cognitive psychology of decision-making, including medical decision-making. And the vast majority of physicians, I think, are totally unaware this literature exists. And it isn't reasonable to think all of us are going to become clinical psychologists, but there are concepts there that are very important that if we can somehow incorporate them into our reasoning, they may help us to recalibrate the reason and improving our accuracy. So subsequent revisions of the card began to integrate selective relevant principles of cognitive psychology of medical decision-making into the clinical concepts developed from bedside experience. And I think the current version of the card is version 19 or 20 or so. Because once I started seeing that literature and looking at what I had totally from the bedside, I was really struck that they just kind of were hand in glove. I was kind of stunned by that. So I tried to start integrating some of those just simple concept reminders into the questions that came from the clinical background. So the hypothesis of what we're trying to do is the following. The hypothesis is that systematic use of a simple list of logical questions to consider in the diagnostic process, based upon principles of physiology and pathophysiology, when combined with point-of-care reminders of pertinent cognitive heuristics and biases, could, if used systematically over the course of a 3-year residency training program, enable physicians in training to recalibrate type 1 decision-making processes and improve both accuracy and cost efficiency in the diagnostic evaluation. That's the hypothesis. And basically what we're trying to do is this. We are taking what is inherently an analytic process, a systematic way of thinking through the decision-making, but seeing if we use it repetitively over the course of 3 years of training, can this gradually be incorporated more into type 1 reflex reasoning, that trainees can begin to incorporate some of these more analytic concepts into their fast reasoning. And as I was going through a lot of this literature, I came across this book, which is a fascinating book, and many of you have probably read it, by Atul Gawande, The Checklist Manifesto. It made a very compelling case for the value of checklists to improve decision-making. And I looked at that and suddenly realized, well, this card that I had was a checklist. Didn't know that at the time, wasn't thinking about checklists, but that's what it is. It's a cognitive checklist. And this is a very fascinating book. And there is substantial documentation of effectiveness of checklists and procedural tasks, which are linear and deterministic. And in medicine, examples are central line infections, operating room, others where checklists have been clearly shown to be effective in improving quality and patient safety. There's less documentation of effectiveness of cognitive tasks where decisions are complex and multifactorial. But there's one example in the book with a hedge fund manager who decided that before his group were allowed to pick any investment, they had to go through a checklist. And the checklist was mistakes that he had seen made or had made in people picking investments. So he required them, before you can select an investment and make that decision, you got to go through this checklist. Did you think of this? Did you think of this? And they found their yield went up a great deal just with that process. More recently, Eli and colleagues have recently suggested that diagnostic checklists might be beneficial in improving accuracy. And they presented several general concept examples of possible types of diagnostic checklists, but there are no generally applicable diagnostic checklists that has yet been proposed. They actually presented an abstract in the meeting this week where they did a little project, but he had 63 different checklists, one for every kind of symptom you see in medicine. So if a patient comes in short of breath, you pick out your short of breath checklist and you go through. And they tried to demonstrate in a small trial that it improved diagnostic care. There was some improvement, but nothing statistically significant. Small number of physicians, small number of cases, and 63 checklists. But it raised the question that the world was starting to think about cognitive checklists and decision-making. Who knew? And here's the current version of the checklist. I actually brought some here today, so if people are dying to have a copy, I have a few here to show you. But this is what it looks like. And I pass it out in the beginning of attending rounds on every rotation. So one point that's very important to make is the purpose of a checklist is not to teach or inform. Okay? You're not trying to educate people with the list. There's nothing on there that isn't simple and stupid. It's just basically putting down what are the logical things we all should do. So the purpose of a checklist is to remind oneself of the information that one already knows, but which is easy to overlook or ignore in the process of decision making. So because you already know it, there's a very consistent and strong cultural bias against checklists when they're introduced, even in circumstances of clearly proven value, such as in operating rooms. The basic thing is, I already know that. I don't need that. Classic example of overconfidence bias. The pioneers in checklists were the aviation industry, and pilots quickly overcame their overconfidence bias because they knew they had to get in the plane. And they began to see the advantage of checklists, and that's where checklists were originally developed and brought into industry and now coming later into medicine. But another point to emphasize is checklists are just a tool. They do not work on their own. You cannot pass out a checklist and go through it and say, everybody use this and expect anything to change. It's not going to work. For checklists to be effective, it's essential to change the culture. The checklist is just a tool for changing the culture. So you put the checklist out there and you change the whole culture in terms of approaches to thinking around this, build around the checklist in terms of administrative mechanisms, teaching mechanisms, how we evaluate effectiveness, all build around the concept of the checklist. So if you just put a checklist out there, nothing's going to happen. But the checklist is a tool to try to change the culture in how we approach our reasoning and decision making. So what are the questions on the card? The first ones are really unrelated to diagnosis, but I've just been so impressed in patient encounters that it's important, is about medications. In every patient encounter, always know the medications. Ask yourself 3 questions. What medications is my patient on? Number 2, what medications are they actually getting or taking? Particularly on inpatients, you'll see this long list of meds. Then you go look in the nursing notes and say, well, that has been held for 3 days because their blood pressure is too low, or they've been NPO getting studies and so forth. So what are they actually taking? And third, and most importantly, what indicated medications are they not on? Just taking a second to ask yourself that question. It's not that we don't know what people are supposed to be on, but it's easy to forget it. It's easy to overlook it. This is a patient who was sent to me a couple years ago now, an 86-year-old gentleman referred for routine consultation for evaluation of coronary disease. He had CABG times 6 in 1996, was referred to, 2011. His son had CABG times 6 at age 46. He's been followed regularly since 1996 by a faculty physician who's also a personal friend of the patient. And when he came to me and I was evaluating him, I look at his med list, and here's his med list. And I'm looking there and saying, I don't see, he's not on a statin. So, okay, it must be he was put on 3 or 4 different statins and he got severe muscle ache and he just didn't tolerate them. So have you ever been on Lipitor or Zocor? No. Well, maybe you refuse them. Did anybody suggest you be on it to take it? No, it's never been brought up. This patient has been followed here by a faculty physician, a good doctor, who's not been on a statin despite 15 years of regular follow-up post-CABG. His numbers, when I saw him, his LDL was 129. Now, all of us, this was a good doctor, and he made a bad mistake. All of us have done that. I've done this, hopefully not for 15 years, but had patients, I'll look at them, and they have heart failure, and I'm looking at it, and I ask myself, what indicated meds are they not on? Well, they're not on an ACE inhibitor. Why not? And then I typically find, well, they were admitted 2 months ago and the ACE inhibitor was stopped because their creatinine was up or their blood pressure was down, never got restarted. So just taking that second to ask yourself, what indicated meds are they not on? I'm certain that that physician, who's a good physician, knows patients with coronary disease and bypass should be on a statin, but somehow it got overlooked. Just asking that question to help. And then the basic premise of this whole approach is that the most important steps we take as physicians are 2 steps back. In every diagnostic encounter in which there's uncertainty, stop, take 2 steps back, and ask yourself, and I have 5 specific questions. This is a diagnostic timeout. It's to stop those type 1 processes, the reflex reactions, say, wait a minute, just stop a second. It's a cognitive forcing function. This is a principle of metacognition, which is thinking about thinking. And to give you a case example to just kind of show how we would apply this, this is a patient I saw a few years ago, 50-year-old woman, 1 to 2 packs a day of smoking, presented with a 1-week history of nasal congestion and dry cough. Night before presentation, she had severe headache with prominent emesis, complained of chills, myalgias, weakness, and chest heaviness. In an outside emergency room, her white count was 27,000, 78% neutrophils, 6% bands. Her PO2 was 77 on 15-liter face mask. Potassium was 5.2, her creatinine was normal, her troponin was 9. Her EKG had nonspecific STT changes. They did an LP because of the white count and the severe headache and so forth. It was negative. They began her on antibiotics and transferred for further management of possible myocardial infarction. On arrival here, she was hypotensive on dopamine, dobutamine, norepinephrine. She was intubated in the ER. She was in sinus tach at 110, nonspecific STT abnormalities. A repeat EKG 3 hours later had 2 millimeters of ST depression localized in the mid-anterior leads. The chest X-ray was read by the CCU team as marked bilateral pulmonary infiltrates. It was read by the radiologist as pulmonary edema. Not clear if the team ever saw that reading or not. An echo was, the white count was 31,000, 80% neutrophils, no bands. Troponin went to 24 and peaked at 40. The echo was technically limited, possibly inferior hypokinesis. Ejection fraction couldn't be estimated. The dopamine, dobutamine, norepinephrine were rapidly weaned, and the presentation was thought to be sepsis with secondary myocardial infarction. She had a CT of the chest, abdomen, and pelvis, which showed emphysema, small bibasilar pleural effusions, bibasilar atelectasis, and possible consolidation. The abdominal CT had a small lesion in the right adrenal that was consistent with an adenoma. Otherwise, the abdominal CT was completely negative. All cultures were negative, although she had received antibiotics prior to transfer. She subsequently underwent a cardiac cath, showed completely normal coronary arteries, no coronary disease. She was treated for community-acquired pneumonia, and she was discharged on day 7 with diagnosis of pneumonia with sepsis. Interestingly, myocardial infarction was not on the discharge diagnosis list. 3 months later, she represented with 4 days of intermittent shortness of breath, then an episode of chest pain with marked shortness of breath. In the outside ER, she was on 10 liters of oxygen was transferred for further evaluation. Her white count was, again, 28.9, 85% neutrophils, no bands, troponin 18, EKG, sinus tach, no acute changes, chest X-ray, moderate to severe pulmonary edema. Echo is technically limited, but the EF was estimated to be 45 to 50%, severe inferior hypokinesis, no MR, PA pressure 45, all the cultures were negative. She was diuresed with rapid improvement. The chest X-ray completely cleared in 12 hours. She remained intermittently hypotensive into the 70s, requiring low-dose dopamine. So the first question that we use in the process is, what am I observing? It's very helpful when you see a presentation to just step back and simply describe what you're observing. Name it if you can. It can be an isolated finding, or it can be aggregate data from the history, physical, and diagnostic tests. Just describe what it is that you're seeing. Use of semantic qualifiers and semantic structure provides a mental scaffolding that improves diagnostic performance. It facilitates pattern recognition, which is a crucial step in the diagnostic process. So just step back and describe simply what is it that I'm seeing. So in this case, it's a 50-year-old smoker who presents with 2 episodes of non-ST elevation MI, complicated by acute pulmonary edema with normal coronary arteries. Associated findings include intermittent chest pain, recurrent elevations of white count with repeatedly negative cultures, hypotension requiring dopamine, and mild left ventricular dysfunction. It's kind of just the description of the presentation. The second question is, how do I explain the findings in physiology? Just if this symptom, how does the body, if you get cramping abdominal pain, what is it? Well, it's constriction of some hollow viscera. Okay? And how do I explain the physiology in terms of pathophysiology? This, again, is causal reasoning and helps avoid context errors, and I think is an extremely important process in the diagnostic analytic process. So on the card, I have a very simple example just as an illustration. Glad to see Jamie Johnson isn't here. I figured he'd be here, and he'd probably nail me on something here. But I said, so a simple observation, you get lab results back. The BUN is 75, the creatinine is 2.2. Well, what's the physiology of that? There are basically three things. It could be pre-renal azotemia, something before it gets to the kidney, intrinsic kidney disease, or post-renal azotemia. So that's the physiology. What's the pathophysiology? Well, the pathophysiology for pre-renal could be volume depletion, decreased colloid oncotic forces, myocardial dysfunction, valvular disease, pericardial disease, GI or retroperitoneal bleeding. These are all things, they're not diagnoses, but they are mechanisms by which one may become pre-renal. In intrinsic renal, it could be ATN. Post-renal could be bladder outlet obstruction. So that would be the pathophysiologic construct. So for this case, myocardial infarction with normal coronary arteries. What's the physiology? What are the possibilities? How do you get an infarct with normal coronary arteries? Well, one may be, maybe the coronaries aren't really normal. Is something missed? Was there a blockage that wasn't there? Could there be a coronary embolism with spontaneous lysis? Or how about in situ coronary thrombosis with lysis? Dynamic mitral regurgitation with secondary myocardial infarction with pulmonary edema. Hypotension resulting in hypoperfusion with infarction due to hypoperfusion. Coronary vasospasm or excessive demand that's outstripping normal supply. That's kind of the physiologic possibilities of how can you get an infarct with normal coronary arteries. So if we then take that to the next step, pathophysiology, are the coronaries really normal? Well, a pathophysiologic mechanism could be, is there a flush coronary occlusion missed on an angiogram, that it's occluded right at the takeoff and you just don't see it? Coronary embolism with spontaneous lysis. So it might be an embolism from the left atrium or the left ventricle. Might be an embolism from a vegetation or a valve. In situ coronary thrombosis. Maybe there's some type of hypercoagulability disorder leading to it. Dynamic mitral regurgitation, pulmonary edema, called or dynamic MR causing pulmonary edema. Hypotension secondary to coronary hypoperfusion. She was documented to have recurrent unexplained hypotension. Were there areas that were previous that were more severely hypotensive that led to the infarct? Coronary vasospasm, she had some variable ST depression, but ST elevation, that's the marker of vasospasm, is dynamic. It might have been missed. May have occurred before she was admitted. We didn't see it. Or finally, excessive demand outstrips supply. So was there marked tachycardia increasing demand, severe hypertension, excessive cardiac output demand by some mechanism? So that's kind of a pathophysiologic framework to begin thinking about her. The third question is, what is my diagnosis? And with this, an important question, is all the information concordant? Or is there discordant information? This is the process of diagnostic verification, diagnostic coherence, and adequacy. What is my diagnosis? Data shows we start getting to that point 15, 20 seconds, 30 seconds into the patient interview. Another related question that's very important at this point with diagnosis is just asking yourself, what's my estimated prevalence of disease? This is invoking the probabilistic reasoning to avoid base rate neglect. Am I diagnosing something that's 1 in a million and overlooking something that's actually quite common? And then I ask, and the way I put this question on there is, am I wearing blinders? Just stop and say, dummy. It's a cognitive forcing function. The whole idea is avoid premature closure, anchoring, availability, confirmation, overconfidence bias. Just stop and say, hey, stupid, are you wearing blinders? Are you missing something? Just making yourself stop and ask yourself that question kind of opens up your mind to start considering alternative possibilities. Which gets to the fourth and critically important question, what is my differential diagnosis? Too often we tend to skip that because we get focused on diagnosis, I know what this is, and we close out other possibilities. There's a real value, even if it's quick, to think, what is my differential diagnosis? Always deliberately, consciously consider the alternatives. Ask, what else could this be? Just the discipline of stopping for a second and asking yourself that question can help overlook important things. This, again, is a cognitive forcing function. It avoids search satisficing, representativeness restraint, premature closure. In military decision training and planning a mission, They train them after you plan a mission, then look at it and always consider the opposite. Consider the opposite of your assumptions. What would happen there? And they teach them prospective hindsight. So once you plan things out, think into the future and then look back and ask the question, what if my decision was wrong? How would that have played out? And if that's the case, how might I have modified my planning up front that might have taken that into account? And this is an appropriate place to consider use of decision support tools. I think that's where they particularly have their value in helping to diagnose, to spit out a list of differential diagnoses for you to consider. And the last question, important question, is what test do I need to order, if any? Okay, not everybody needs a test. It seems radical to say that, but this is the step of diagnostic verification. And this is very much a part of the ABIM Choosing Wisely program. What test do I need to order? And begin thinking critically about that. And under this, I have a number of questions, and ones that I use on rounds. Okay? One is, what specific question are you asking with that test? When you start asking that, you'd be amazed how many tests you see ordered, and when you ask them, what question are you asking? What specific question? They don't have an answer. Okay? Because we say, oh, they have heart disease, get an echo, or get a CT or whatever, without stopping to think, well, what am I trying to find out? What question am I asking? My rule with the house staff is, if you can't answer that question, you can't order the test. Related to that, do I need to know the answer? Will it affect my diagnosis? This is post-test hypothesis refinement. Will it affect patient management or patient outcome? I'm asking this question, is it going to make any difference? Is it going to change anything I do? If the answer is no, then why do the test? Do I already know the answer based on information already available to me? And is this the right time to ask the question? I can't tell you how many times I've seen patients come in middle of the night, they go to the cath lab, acute MI, they get a stent, they may even have an LV-gram. Fred's seen this too, I'm sure, and they come out of the cath lab with an order, echo and AM. Well, what the heck are you getting an echo for? You just did an LV-gram, or even if you didn't. Well, I want to know what the ejection fraction is. Well, their troponins 200, and they've cued out their anterior wall. What do you think their ejection fraction is? Okay? Or their troponin is 1 and their EKG is normal. What do you think their EF is? It's not that EF isn't important and that we want to get it, but we reflexly react to it, and is this a time to ask the question? I don't want to know what their ejection fraction is 12 hours after the infarct. If we're thinking about a defibrillator, we want to know what their ejection fraction is 3 months later, because you can't put in a defibrillator until then. If you're thinking about, do I need to put them on anticoagulation 3 or 4 days later, not the next day or the next morning. Here's just an example that I've had a 66-year-old woman with heavy smoking history, patient of mine, severe oxygen-dependent COPD, severe bronchospastic component, prior AVR with severe AS, chronically elevated prosthetic valve gradients, coronary disease post-CABG, known to be incompletely revascularized, not amenable to further revascularization, chronic heart failure with systolic and diastolic dysfunction, stage 5 chronic kidney disease on hemodialysis, not a candidate for surgery under any circumstances. She had 7 admissions to the internal medicine service in 14 months, all with severe shortness of breath, plus or minus chest pain. She had an echo done on every admission when she came in short of breath. Here are all the results. Now, this is back in 07, 08, and I know we're much better now, and this never happens anymore. But it's a good example. And so, if a patient comes in with severe lung disease, known severe heart disease, kidney disease, and volume overload, how is an echo going to help you know why she's short of breath or what you're going to do? What are you going to do? You're going to treat her with bronchodilators. You're going to diurese the hell out of her and get fluid off. You're not going to do anything else. But this lady had 7 echoes in 14 months. You see the variability of the measurements in terms of size and ejection fraction and mean gradients and so forth. So it's just a reminder. My experience has been when I use those 4 questions on attending rounds, we start the first day, I give the card. Okay? We start making rounds the next morning. About 25% of the studies ordered during the night, either by our staff or our consultants, who come by and say, well, get this or get that. My rule with the house staff is make them answer those questions. If they cannot answer those questions, do not order the test. And about 20-25% of tests get canceled the next morning, unless the patient's already had it done. They whisk them off to the echo lab first thing or the CT scan or whatever it is. But when we start applying that, and then during the course of a couple weeks, that percentage starts going down because the house staff realize those are the questions they're going to have to answer, and they start getting more critical and thinking about what they're ordering. Another question related to what test is, will the test that I'm ordering answer the question that I'm asking? I've identified the question. Will the test answer the question? To know that, you have to know what's the sensitivity and specificity of the test, and what's the pretest probability of disease. This is pretest and conditional probabilities. If it's a low sensitivity test or a very low pretest probability, even an abnormal result is overwhelmingly going to be a false positive. So is the test that I'm ordering going to answer the question I'm asking? And a very important one that I think we terribly underestimate is, what is the error rate of the test, post-test probability? Every test has an error rate. And as physicians, I think we tend to underestimate just how much of a problem this is. Just a few examples of literature. Here's a study, Mass General, 90 abdominal and pelvic CT scans reported by 3 experienced radiologists who specialize in abdominal imaging were randomly selected from the database. So these are faculty specialists in abdominal imaging at Mass General, so probably pretty good docs. The same radiologists were asked to reinterpret 60 studies in blinded fashion, 30 that they had interpreted originally, and 30 that another radiologist had interpreted originally. The intra-observer discrepancy was a third, 32%. 1 out of 3 cases. When the radiologists reread the same CT scan they read before, they had a different significant find in 1 out of 3 cases. Interestingly, the inter-observer variability was a little less, 1 in 4. But the point is here, we tend to think of these readings, and think of a radiologist's life. CT scan has 1,500 slices or whatever, and they're doing, they have 5 minutes to go through one, they're going through them fast, and we think of these as gospel. But every test has error. Here's another report I just picked because it's in this month's Annals of Internal Medicine. Caught my eye. Prospective assessment defining limitations of thyroid nodule pathologic evaluation, both by aspiration of the nodule and then postoperatively by histology, looking at the diagnosis. The inter-observer agreement as to whether it was benign or malignant was 90%. As you've taken it out, you're slicing it up, you're doing all the pathology. In 1 out of 10, there was disagreement. This is cancer or not cancer. It's a pretty basic decision. But in 1 out of 10, there was disagreement. When you look at aspiration by central cytopathologist, it was in the range of 75% agreement as to whether it was cancer or not cancer. And here's a final example of a case that I just saw last month. A 48-year-old patient with known dysautonomia, orthostasis, positive tilt table test. He's a detective. Stable on medical therapy, seen for routine annual evaluation last month. His physical exam had a new 2 to 3 out of 6 apical systolic murmur, which to my ears augmented notably with Valsalva maneuver. So I ordered an echo with a suspicion of hypertrophic cardiomyopathy or maybe severe MR. And here was the echo report that came back, and it describes a little bit of left ventricular hypertrophy and an ejection fraction of 79%. That's pretty precise. And you look through, everything's there, and you come down, and normal left ventricular size, wall thickness consistent with LVH, normal systolic function. It's reported. Well, wait a minute, this doesn't explain the murmur that I see. Something's wrong here. So I go over to look at the test, and we find that at the end of the test, they had done a Valsalva maneuver because I ordered it to rule out hypertrophic cardiomyopathy. And with Valsalva maneuver, the left ventricular gradient went to 64. And with amyl nitrate, the gradient went to 200. So this was a test that was reported out as mild LVH, which in fact was severe hypertrophic cardiomyopathy. Now, how did that happen? A couple possibilities. Busy lab. They're transferring the images. Maybe the last couple, it was the last part of the test. Maybe they didn't get transferred to the reading station correctly. Or maybe the person reading was in a hurry, reading a lot of tests, and that was on the last page and didn't see them. But somehow those findings did not get into the report, and an amended report came out. The point is, every test has a significant error rate. And in terms of diagnostic error, we need to always consider them. The other last questions relative to the test are, what are the risks of the test in general, and in this patient specifically, things like contrast-induced ATM. diabetic with creatinine 1.8, I better start thinking about that. Can anything be done to reduce those risks? And do the potential benefits justify the risks? And then finally, what are the costs of the test? Are there alternative tests to consider that might be preferable based upon accuracy, risk, and cost? And this gets back to the current initiatives in terms of picking up decisions. So if we go back to our case in pathophysiology and look at tests that were done, in terms of the question, were the coronary arteries really normal? Well, a repeat coronary angiogram with ultrasound mapping showed no flush occlusion. So there wasn't an obstructed artery that was missed. Coronary embolism, could it be a patent foramen ovale or an atrial myxoma? An echo and a bubble study, no shunt, no PFO, no myxoma. Well, what about a vegetation from valve? A transesophageal echocardiogram, no vegetations anywhere. In situ coronary thrombosis, hypercoagulability workup was negative. Dynamic MR, pulmonary edema, a stress echo was done, no provocable mitral regurg. So that's not the cause. Well, how about hypotension with secondary perfusion? She was documented to have recurrent unexplained hypotension. Was there more severe hypotension? We did a Cortrus and stim test. She was not adrenally insufficient. Her TSH turned out to be 40. She was started on Synthroid, and we're kind of scratching her head. How's that fit in? Unclear, but she was profoundly hypothyroid. Extensive cultures were all negative, so there really was no indication of sepsis, despite the elevated white counts. Coronary vasospasm, she did have ST depression. ST elevation is dynamic. Prolonged monitoring and 2 CCU admissions, she never had any ST elevation, but she also had no clinical episodes during monitoring. So it's possible that that was there and could have been missed. Excessive demand outstrips supply. Well, she never had marked tachycardia, never had documented severe hypertension. Excessive cardiac output, she wasn't markedly anemic, she had no AV fistula, none with the explanation. So we come back to what tests am I going to order? A premise that I have, and this is actually up high on the list, but I, for this discussion, put it toward the end. The most accurate and cost-efficient diagnostic test that we have is a careful history, personally obtained, with a focused physical exam. So in desperation, we go back to this patient and say, okay, let's start over. Now, when she came in, we thought we'd taken a pretty careful history, but she came in, she was on 15 liters of oxygen, she was short of breath and so forth, took a history, so went back. And the whole idea of the history is to avoid framing bias, and critical to this is focus on pivotal questions. Focus on questions that help you differentiate this versus this, a turning point. And so we went back again to do a history. Found her symptoms were worse with stooping or bending. Both episodes of severe shortness of breath began while stooping. The most recent one, she was sitting, bending over with her legs crossed to tie her shoes. Both started with chest pain, nausea, diaphoresis, then prominent headache, and racing heartbeat. And she had symptoms of tremulousness and anxiety, headaches, and excessive sweating for 2 years. Another premise in terms of testing is the best first test to do is to review any prior tests. So we went back and noted on this prior CT scan she had this adrenal nodule, which had been disregarded on the prior admission as an incidentaloma. So based upon the additional history and that finding, we decided to order urinary catecholamines, which showed her metanephrines to be 14,000. Her normetanephrines 4,700, metanephrines 9,200. Her pheochromocytoma was excised and she was cured. Now, if we were more on the ball, way upstream with all that logical testing, if the lesson taken home for us there was be really careful with your history, what a valuable tool is. If we had done that before, we could have saved some of those other tests if we'd been more critical in the history. It's the most valuable tool we have. So, can a cognitive checklist help us to teach bedside decision-making more effectively? Unknown. I don't know the answer to that. Nothing like this has ever been attempted at an institutional or training program level before. For checklists to work, you have to change the culture. It's not about the checklist, it's about changing the culture. So there must be consistent and sustained commitment to it from the faculty if this is going to work. And it must be taught longitudinally over time. It takes repetition to convert those type 1 reasoning functions into a type 1, or the type 2 reasoning functions into a type 1 heuristic. And the last question is it possible to measure the effect of teaching this on accuracy and efficiency? It's a tough problem. How can we measure what we're doing? Is it good? What works? What doesn't work? I've thought about possible case simulations where we might use test cases and test the current interns, first-year, second-year residents as a baseline, put this in the curriculum at the end of the next year, test the current new interns, first years and second years, and see if there's a difference. That's just one thought. Under the Center of Clinical Decision Making, we do have a $500,000 grant over 2 years from Hearst Foundations to fund collaborators, in part to fund research. So I'm hoping to attract people who may be interested and a lot smarter than I am to try and figure out how we might study this. And I'll finish with this slide, which also is timely. It's an email that was sent to me, Jen Corbelli, August 30th, unsolicited email. Hi, Dr. Follansbee. I'm one of the Gen Med faculty. I worked with you in CCU when I was a resident and just wanted to pass something on that I thought you'd appreciate hearing. I started on service this week, and I've been talking to my team about taking 2 steps back. This morning, we picked up a patient who was transferred from an outside hospital overnight with headache and a CT scan showing a subdural hygroma. Neurosurgery saw her overnight and felt the hygroma was old and resolving, and there was nothing to do about it. It would have been very easy to just treat her pain and not rethink the case. Before I spoke to my team about this patient, they really took 2 steps back and redid a careful H&P with an open mind. It turns out her symptoms are concerning for temporal arteritis, which had not been considered by anyone who saw her overnight. She was started on empiric pulse steroids and asked ophthalmology to see her. I just thought it was a great example of what you always teach, so I wanted to share that with you. So I'll end with that. Thank you.